So I'm a current colorectal fellow at the University of Manitoba in Winnipeg. This research was and is still being performed back at my residency training site at Memorial University. I have no relevant disclosures for the talk, nor do any of the authors of this talk have any relevant disclosures. There was no funding provided either for this study. So as we know, colonoscopy is widely accepted as an effective screening and interventional modality, and since its widespread adoption has been linked to decreased incidence and mortality of colorectal cancer over the years. It's largely operator dependent, and so there's been a lot of research put into identifying quality indicators and associated techniques to optimize on those quality indicators. One such topic is on insertion techniques, which can be facilitated using water infusion or air insufflation, as we all know. A great body of literature, like a lot of literature is out there to support water infusion as a superior method over air insufflation on multiple quality indicators, including adenoma detection rate, cecal intubation rate, and patient comfort, as well as other factors. There is a lot of literature out there, but a lot of it focuses on experienced endoscopists almost exclusively. But we all know that in many academic and non-academic centers, a lot of these colonoscopies, at least in part, are performed by learners at various stages of their training. So what our group was interested in looking into was, do these effects translate into learners? So what we did this study, the learners of interest in our study were general surgery residents at our site at Memorial University. Due to the curriculum, they don't start their endoscopy curriculum until the PGY3 year. And we waited, they were not included in the study until they had performed at least 2 months of this endoscopy curriculum, just to ensure a baseline level of skill. For every single procedure that they performed, they were randomized into either water infusion or air insufflation exclusively for insertion of their colonoscope. Instructors were instructed not to sort of touch the scope for the first 15 minutes, and after 15 minutes, that would be considered an incomplete colonoscopy just for the sake of being able to sort of complete your colonoscopy list for the day. Our primary outcome was cecal intubation rate, but we did look at a number of secondary outcomes as well, including transverse colon intubation rate, in other words, getting around the splenic flexure, which is considered one of the more difficult parts of the insertion of a colonoscope. We also looked at time to cecal and transverse colon intubation. We looked at these factors by year of training as well. We also looked at patient comfort level, both reported by the resident and the nursing staff, and sedation dosing requirement needed. Additionally, on top of the clinical outcomes, we were interested in educational outcomes as well. How does this affect the trainees' learning and their perception of their learning? So at the end of every single procedure, the trainees were given a 4-question survey consisting of Likert scales to look at their perception of the difficulty of the colonoscopy, their personal performance on the scope, their perception of how comfortable the patient was, and their overall satisfaction with the learning experience. So this was for each procedure that was performed. Our objective measure of patient comfort came from the nursing-administered patient comfort scores, which we already assess for any procedure performed in the endoscopy suite at our center. And as you can see, there's multiple factors here. A higher score is considered worse in this domain. 3 factors looking at pain, 1 at sedation level, and just global assessment of the patient's tolerability of the procedure. At the time of this interim analysis, we've accrued half of the study procedures, which is 71 cases of the 142 that were required for the powering of the study. Overall, most of the procedures have been performed by PGY3s and PGY4s, and a few by PGY5s, and that's consistent with how our curriculum works, as that is when most of the scoping happens in our curriculum. Our overall transverse colon intubation rate is about 80%, with the cecal intubation rate just over 50% amongst all learners at different stages of their training and with both insertion methods. Our average time to transverse colon intubation is 7.8 minutes, with an average cecal intubation time of 9.5 minutes. And again, if the scope gets to 15 minutes, for the purposes of our study, that's considered incomplete, simply because we didn't want this to affect clinically being able to get through your scope list during the day. So at the time of this assessment, 48 procedures had been performed with air infusion and 23 with air insufflation and 23 with water infusion. So we've basically double the amount of air ones just by the way the randomization has worked. We've got it at multiple different sites happening. Most of our factors so far have been equal in terms of patient demographics, although there is a significant difference in the weight between the 2 groups, with the water patients being a bit heavier. The quality of bowel prep has been equal between the 2 groups compared to, as assessed by the endoscopist. So looking at the intubation rates, our primary outcome being the cecal intubation rate here, we are seeing a trend favoring water. So far, none of our results have been significant, but we're seeing notable trends. So the transverse colon intubation rate and the cecal intubation rate both similarly seem to be improved with water infusion over air insufflation. Again, looking at times, it's a less notable difference, especially with the transverse colon intubation time, but we are seeing improvement with water compared to air, more notably with the cecal intubation time. So after they're around the splenic flexure, it seems to be more of a factor for time from what we're seeing so far. Looking at year of training, this is just using both water or air, kind of the catch-all. Looking at the intubation rates by year of training, we are seeing a trend of increasing intubation rates as the residents are going on with their learning, which is exactly what we'd be hoping to see at this point. Interestingly, all of the PGY5s, although there haven't been that many included in the study, have a 100% ability to get around the splenic flexure so far. So I feel sorry for the person who ends up breaking that streak. Looking at sedation usage, the standard at our center typically is about 50 micrograms of fentanyl and 2 milligrams of midazolam. And so any increase in that dosing is usually related to a need to redose. And if you look at the midazolam dosage, the dosage doesn't seem to be affected by whether you're using air or water, but we are seeing a difference in the fentanyl dosage, and that's quite close to significance, so we're thinking we'll get there probably soon. So people getting the air infusion air insufflation do seem to be requiring a redose of their fentanyl. And again, this is based on patient endoscopist and nursing assessment of whether they need it intraoperatively. And then separately, we looked specifically at whether they were redosed. Some patients did get, a higher dose at the initiation of their procedure. And we are again seeing a trend for increased need for redosing of both medications with air compared to with water. Looking at our educational outcomes, comparing air and water, we're not seeing a huge difference between the two. Again, certainly not significant, statistically significant, but we are seeing that there is a slight trend of favoring water over air for the resident reported outcomes here. Fairly similar. The one that we're seeing again, you can see visually a bit of the biggest difference looking with patient comfort. And this again is the resident perception of the patient comfort. So they're believing that with the water infusion, the patients do appear to be a bit more comfortable during the procedure. Other outcomes that we're looking at so far, so the NAPCOM score, that's the nursing assessed patient comfort score. So that is considered our more objective measure of the patient comfort score. And it does seem like they are considering the patients to be much more comfortable with water compared to air. And position changes, which is one of our pseudo markers of ease of scope, which is one of the things that we're looking at. And we are seeing that patients are requiring fewer position changes when scoped using water compared to air. Not yet significant, but we're hoping. So in conclusion for this study, this is an interim analysis. We haven't yet had any significant changes, but we are seeing a strong trend favoring water infusion over air insufflation for essentially all of our outcomes, including intubation rates, times, patient comfort, as assessed by nurses and residents, sedation usage, and other educational outcomes. We are expecting, based on data that is used across Canada loosely, you'd expect a cecal intubation rate of about 90% by the time a resident is graduating, and we are hitting that. Our residents in PGY5 are getting about an 89% cecal intubation rate. So that's another secondary outcome that we're happy with seeing. There is a trend towards significance, and we're anticipated that once the accrual is finished, we're hoping to achieve that. Thank you, everyone, for listening.